Jamie and Tatum and I were trying, but yeah, no motivation.
You guys have your textbook?
So just informally,
Your mid-search textbook?
Yes. You brought it up.
what do y'all expect for the fall?
What do you expect?
Uh-huh. You kind of worried about how
I
it's all gonna play out?
I don't have any
I feel like
expectations.
since we went
Okay, keep
halfway
in
through
touch
the program,
with your instructor. Right now, classes are going to be synchronous.
Mhm.
Do not schedule to work during class time or clinical time.
Right.
The synchronous class is my personal favorite because you get all the benefits of the classroom with none of the germs.
Okay.
The clinical will be in clinical.
Okay.
I don't know what preceptorship though will look like towards the end of the semester, but they will inform you the first 2 weeks of class. During your first week, you will be here for your clinical time. I'm sending it out to them after I finish up here. So during your class time, or your clinical time, I think they'll have 15 people do one thing and 15 people do the other thing, so that we can like distance a little bit, and try to keep the clinical partners together so that you're only exposed to one or two other people in the course of your day.
Right.
But you'll be doing simulation for both clinical days. Now, what that looks like, I'm not quite sure. I don't know if he'll have half of you just go to your campus or your classroom and do activities there for the one day. So, anyway, that's the scoop so far. That's the scoop so far.
Are you guys working right now?
I am.
Okay, where do you work?
Adventell in Orange City.
Oh, in Park City.
That's the other thing, is that we're looking into how we can do it and help students to procure, but you will need for Advent, which I think Mr. Arrington goes to Halifax. They're not requiring, but I would say it's a good idea. Eye cover.
The face shields.
A face
Or
shield is
goggles.
preferable in addition to the mask.
Okay.
The face shield or goggles? I think they have goggles.
Goggles are fine, but since you have glasses, you have to use
The face shield, yeah, it works
the
better.
vented goggles that,
Oh.
come out like telescope. You kind of look like one of the minions.
I'm already struggling with like the glasses fogging up, like I try to pinch this as hard as I can, so yeah, it's a struggle.
Okay, so just so you know, this young lady over here is videoing this so that I can YouTube it. And once it's YouTubed, it's gonna go to all of your classmates that weren't able to make it. I had 5 people signed up for today. Obviously, we have 2 of you here, a couple on the way. And I've had multiple people tell me that, oh, I was exposed to COVID. And so, until my test comes back, I don't want to expose anybody else. And
Right.
were very responsible, did not come in. And I'm happy with that. That's cool. How to play out in the fall is if you get exposed and you have to self-quarantine for the 14 days, you'd be missing 4 clinical days. And so you may have to withdraw and readmit. Now, what they have said,
Oh my God.
I
that'd be
mean,
awful.
what they have said is that, that one readmission rule, if it's because of that in specific, they may waive, but I don't know.
Girl.
I know.
Oh my God.
No,
I'm off?
it's not happening.
I really can't get somehow. I'm done.
Okay, so let's go ahead and get started. Woohoo!
4th semester, here we come.
Yes.
Here's your classmates. If you would both kindly sign in.
Natalie just drop this down.
And then grab one of each of the handouts.
And you and Ken's camera.
Oh, okay.
I was just telling your colleagues that the reason we have her here, this young lady is videotaping us. We're gonna put it on YouTube,
Oh, nice.
the college's YouTube channel, and hopefully just post it to the Student Success website so that you'll be able to go back and review, or your colleagues who could not be here can see it. Okay, so welcome to 2940. Moving forward to your final semester.
Dun, dun, dun.
I know, eh? There you go.
The end is on the way. You survived third semester without clinical or classroom. You made it to this point, so yay. Okay, so in this final semester, you hit the ground running. And when I say running, your math test for medication calculation is the very first week. You are expected to know trach care. Yes, they will do a demo and give you a couple of hours to do some practice, but you're gonna sign off on trach care in the very first week in most cases. And that'll be probably here in simulation. But just keep that in mind, that when I say you hit the ground running, I mean it. You have 8 short weeks to prove yourself in clinical. And actually it's more like 6 short weeks to prove yourself in clinical, and then you're off to your preceptorship. So this class is fast-paced. And if you missed, or if you made it through third semester, you should be just fine. I'm not trying to scare you. I just want you to know that it's really fast-paced. So you want to get, the fact that you're here is a good thing, because that means that you are ready to take notes, ready to get back in, and you're ready to basically succeed. So what I have done is I've given you 2 handouts. The first handout I'm going to go over, and that is studying smarter, not harder. Okay? This is basically what every nurse needs to know to take care of their patient. Now, I made it pictorial on there on the front of the sheet, just because I like to put it up on the wall. So I'll put each different little thing in its own little bubble, and then I'll put it up on the wall so I can make connections between this and that, and this and that, just the way I operate. But this is a great way to take notes, and it's what we're gonna ask you on an exam, what the state boards are gonna ask you on an exam. So these 5 questions are the root of all nursing questions everywhere. Because it's really what the nurse needs to know to take care of the patient. All right, so we're gonna start with physiology. Do you all know about www.medcomrn.com? Okay, well, it's www.medcomrn, no spaces, medcomrn.com/Daytona State. When you go out there, you're gonna enter a lot of demographic information. They're gonna ask you for address, your phone number, all kinds of weird things. Don't be frightened, they're not gonna charge you for this service. It's paid for through the library. There are 202 videos out there, and those 202 videos are all kinds of different topics having to do with nursing. There are some out there for nursing assistants and for LPNs, but for the most part it covers the ADN curriculum pretty well with different videos. So if you're a visual, go out there and watch some of the videos. So you have homework on MedCom. Your homework on MedCom is to go out there and look at the pulmonary anatomy and physiology, or anatomy and physiology of the respiratory system. Ostomy suctioning video. Each video is between 15 and 30 minutes, so we're not talking a whole lot of time here. Pop your popcorn, bring your notes, and watch the videos and take notes on what you need to do. Or just refresh your memory on the anatomy and physiology. Okay? I don't know if there's an ARDS one out there, but that's kind of where I'm going to frame this talk today. But I'm going to do it using that. Okay, so now you have some things you can do. You'll be able to practice your trach care. Now this sounds absolutely ridiculous. You're thinking, oh my God, how do I practice trach care without a trach? Well, what you're going to do is take a bed pillow, preferably a nice firm one, and sit it on a chair. And then you're going to take a water bottle or a soda bottle or can and tape it so that the hole is sticking out the front. Next, you're going to take a second pillow and kind of bunch it up until it's into like the face of a circle. Put little eyeballs on it and a little smiley face on it. And what you're going to do is just take that down on top of the pillow that's in the chair. And now you have a neck hole. It's a trach. Now to clean the inner cannula, just get a straw. And you'll do your suctioning. You can take out the inner cannula with your clean hand as opposed to your sterile hand. And then you can do your suctioning. Normally you do your suctioning sterilely and then you're clean and you can touch the tracheostomy. But a straw you can't get the catheter through. But if you set a straw in there, you can actually take out an inner cannula and clean it. So you can just take it out and place it into the saline, do your suction procedure sterilely, and then whenever you're ready to clean the rest of the tracheostomy, you can. Okay?
And just to add another resource, don't forget your ATI as well.
Okay, so let's talk about physiology.
Here you go.
Oh, the chalk went away. This is your alveolus, and this is all of the little blood vessels that go around your alveolus. Does that make sense to everybody? Now, I can't draw worth anything, but the whole idea here is that in order for gas exchange, CO2 comes out and goes up and away, and then O2 comes in, and then you have to have the meeting of these two in order for exchange to occur across the membranes. And it's basic diffusion osmosis, where things move from a higher to a lower concentration to try to equal out. In ARDS, or acute lung injury, the physiology is such that the alveolus cannot expand. It becomes stiff. And so it's not going to do the expansion and contraction that we would expect, and so it really doesn't meet those blood vessels. Now we can engorge the blood vessels by overhydrating, but that only works so far, because then if their heart is messed up or inefficient, then they're going to build up fluid everywhere else too. And crystalloids which are clear fluids that we would give in an IV, aren't enough to really expand that too much. So that's the physiology of acute lung injury. We're not going to ask you many questions on the physiology or the anatomy, but it's helpful to understand how it occurs so that then you can understand why we're doing what we're doing to treat the patient. That said, let's go ahead and talk about question number 1. Question number 1, who should the nurse suspect might have it? These are all written down for you in that packet. Flip to question 1. There you go. All right, so question 1, who should the nurse suspect might have it? Why is that important to us? Why does the nurse need to know that information?
You mean like non-modifiable and modifiable risks?
Uh-huh, that's exactly what I'm talking about. But why do I need to know that?
That'll help determine how we treat it, possibly, or how to.
Just to determine the problem.
I'm taking care of the 4 of you. The 4 of you are my assignment. I know that she has been in an automobile accident and recently had sepsis. I know that she's in for an MI and she's in for, let's say, cellulitis in the leg, and you're here in the hospital for
Burns.
So we'll know the
Burns.
signs before, like, so we'll figure out the signs before it happens, or?
Yeah, we're screening patients.
Like this one.
So I know that patients with a certain profile in their history are more at risk for developing ARDS or acute lung injury. And so I'm going to screen her the most because she has the most check boxes. Okay, so dig out those textbooks and tell me for acute lung injury / acute respiratory distress syndrome, what your risk factors are and or etiology. Does anybody know what page?
It starts on 612 for art
Try 612.
and the older.
Reasonably somewhere in that neighborhood. I need you ladies to socially distance. We'll get you a book to look at.
Oh, okay. It's fine.
Or we'll get you a book to look at.
So common causes.
Common causes. So risk factors, yeah. Who's at risk?
Patients that have experienced shock, trauma, serious nervous system injury. Pancreatitis. Fat and amniotic fluid emboli. Pulmonary infection, sepsis.
Okay, so we've got shock, trauma, injuries. What kind of injuries were they?
Just pulmonary.
Huh?
Nervous system injury.
Nervous
Yeah.
system injuries. Pancreatitis, sepsis, fat or fluid emboli, pulmonary infections. Anything else?
Inhalation of like toxic gases and pulmonary aspiration.
So my patient that I had on Sunday, literally had ARDS, came in, he aspirated on his vomit. And developed ARDS. Short time, 100% oxygen, had to increase his speed.
Now, Now, this aspiration pneumonia that turns to ARDS, if they're choking on their own vomit and their vomit gets into their lungs, that's actually the toxic gas inhalation. You can imagine that hydrochloric acid is probably not good for somebody's lungs. And that's what's in your stomach. Okay? So people who have had some sort of shock to their entire system, their lungs could get stunned and have this negative reaction of failure, essentially, which is these stiff alveoli. Some people will call it acute lung injury, progressing into acute respiratory distress syndrome. And other people use those terms interchangeably. Thank you. Okay, but now we have to consider that anybody that has any of these in their history is more at risk for developing ARDS, so we can start looking for signs and symptoms in them. But before we start looking for signs and symptoms, we go to question number 2. Question number 2 is, how should the nurse prevent or minimize the risk? So if I'm talking about aspiration pneumonias or aspiration of food or fluid, what's my best intervention?
Fluid restriction? Yeah.
Uh,
Fluid restriction.
No, we don't want to necessarily restrict them unless they need it.
So this is the less invasive you're talking about?
And like aspiration, like, well.
Prevention of
prevent it.
aspiration pneumonia.
Positioning.
Risk for aspiration. Yeah, positioning. What about it?
They should be in a semi-bowelers? Or bowel
More
position?
specific. It's 45-degree angle. And then for people with like an injury, a neurologic injury, like a brain tumor or a stroke, we want to do a swallow study. And we want to look for specific things that would cause, or that would tell us that this patient is aspirating. And does anybody know what a swallow study does? Okay, you'll also be covering stroke this semester, and that's okay. But with the swallow study, they go from a water that has barium in it to a nectar consistency, like the juice that comes out of the pears in the can, to a, let's see, nectar and then honey consistency. And honey is a little bit thicker. And then they go to like a really soft puree, but still mushy, but solid. And then they'll go to like a bread, which is a soft mechanical, and then they give you a crunchy cracker. Actually, the last time I heard, they were barium-infused vanilla wafers. You couldn't taste the barium, I tried one. Okay, but they use those to determine if there's any silent aspiration going on that can be seen on fluoroscopy. So we just need to know if the patient's allergic to barium prior to them going. And afterwards, we want to encourage them to take a little fluid. They're not going to know that they're passing the barium, but it's all going to come out in the stool. But we do a swallow study in order for us to know if the patient is aspirating. and it's pretty definitive. And then the speech therapist who reads the study will give us a recommendation for how their liquids should be presented or what kind of foods they should eat. In extreme cases, we would put in a PEG to prevent aspiration pneumonia. And while they're eating, we want them at least a head of bed 45 degrees, and usually the head forward. Try it. Put your head forward. Take a breath. Now swallow. All right, now put your head up in sniffing position like you're sniffing a candle. Take a breath. Now swallow. Do you notice how much easier it is to swallow with your head forward? And it's a little bit more difficult to take a breath than the sniffing position, which is the position they tell you to put people's heads in for giving breaths in CPR. That opens your airway and you have an easier time breathing as opposed to swallowing. You have to make an effort to swallow. So that's why we're saying 45 degrees, put their head forward to eat. 90 degrees is really the best for feeding if they're at risk. And that will help prevent aspiration pneumonia. If they're in a chemical industry, we need to provide them with PPE protection. This mask would probably not be enough for certain industrial areas. For example, if you work in the painting industry, you paint cars for a living, you're enclosed in a big booth with a bunch of paint fumes. You think that might cause some inhalation? I put exhale, but it's inhale. So if you are in that room with the paint fumes for any given period of time, you could trigger ALI/ARDS. So we want them to wear the big carbon filter masks, better than N95. I mean, they filter out every little particle because that paint is really tiny. Now, for shock and trauma, we want to prevent them from getting there. So we're going to do some public service announcements on no texting and driving, no drinking and driving, driving at the speed limit, not 50 miles above the speed per hour above the speed limit, being careful and vigilant while driving. We also want to prevent things like people falling off roofs, securing your ladder whenever you're working on your roof, or call in the professionals. For shock, there are so many different kinds of shock. You learned about those shocks last semester, so I won't belabor that one. We talked about neuroinjury, pancreatitis, good organic diet that doesn't include too much alcohol and or sugars. Sepsis, we can screen them for C-reactive proteins, and sepsis releases all kinds of nasty little chemicals in your body. It releases cytokines, bradykinins, histamines, and so forth that can trigger an acute lung injury response. So if we have a patient in sepsis, we want to treat them. Okay? We want to get them antibiotics when they need the antibiotics. Antifungals, antivirals whenever they need them. And then fat or fluid emboli, that's, those patients post-op hip and knee that had have had long bone injuries, that's the fat emboli. So we want to make sure that we screen for any kind of emboli. Pulmonary emboli are very common. My brother has 2 pulmonary emboli. He's got a saddle block. Well, that puts him at a higher risk. So, we want him to take his Coumadin on a daily basis. And then we want him to get checked for INR frequently. And then pulmonary infections. Think about your COPDers who get on an airplane. Here's my funny story for the day. I used to travel for the simulator company all over the United States, teaching people how to use their simulators. The very first summer I worked for them, I had colds every month. I never stopped coughing for 2 months straight. Well, I was in an airplane every other week. Twice. So I started taking airborne and I started wearing my scarf wrapped around my face twice. Essentially 5 layers or 4 layers of thick material between me and the airplane circulation. I stopped getting sick. I wasn't sick once in August. Or no, July or August. May and June, I was sick the whole time. So we want them to protect themselves. Wear a mask when they're in public. Make sure that they don't get close to people who are sick. Wearing eye protection, maybe, so that they avoid those germs. So we want to avoid pulmonary infections. Okay, that brings us to the next item up for bid, which is question number 2 was, how do we prevent or minimize risk? Question number 3, well, they got it. No matter what I did, they got it. Therefore and ergo, how will the nurse recognize the problem? So this is basically clinical manifestations or signs and symptoms. And I want 2 different lists. I want in order of appearance. So I want an order of appearance, which is how it chronologically shows up. So the very first symptom that I might see would be what? An increase in respiratory rate. That's it. That's the very first symptom. And then this is going to progress going to progress and progress and progress and progress if we don't take action quickly. The patient will end up in respiratory acidosis. They will have failure, respiratory failure, and then eventual death if we don't intervene. By the way, there is currently still, to this day, a 50% mortality rate for patients who get ARDS. 50% is really high. Now, obvious over here, the order of importance. I'm going to take that same list and I'm going to put them in order of threat. So obviously, respiratory failure and death is the biggest threat, all the way down to an increase in respiratory rate. Same signs and symptoms, 2 separate columns. The nurse is caring for a patient at risk for developing ARDS. what would be the first indicator that ARDS exists for this patient? You're going to go down this list because they're asking for the first. Now, the other one also uses the word first, but the nurse is caring for a patient with ARDS. What is the first most important assessment data? Well, what's your threat level? So we're looking for an assessment. All of the things that occur on the list are assessment. So now they're chugging like a freight train, trying to breathe. And they have extreme air hunger. Now that occurs maybe down here. If respiratory failure and they're no longer able to breathe is on the list, which is doubtful, but if it were, that would be the most life-threatening. Okay. Okay, so we have a bunch of different lab and diagnostic studies that we can do. The primary lab one is going to be the ABG and the hemoglobin and hematocrit. The reason we look at ABGs is because that'll tell us whether or not gases are being able to be exchanged. What is the nurse's responsibility before doing an ABG? Now they can do them brachially, radially, or femorally. And we don't draw them, but we have responsibility to make sure we know something. What is it?
Wash your hands.
Hard.
Wash your hands.
Well, we should always know to do that. Okay, can I get one of you to join me up here? So we can see it on the video?
Good, Monica.
Okay. I just washed my hands. Okay, so we're gonna kind of point this way.
Good for video.
It's okay. We know you're in street clothes and you're not professionally run. Okay, so I'm going to find your pulse radial. I'm going to find your pulse ulnar, and I'm going to squeeze. Okay, now show everybody the difference between your two hands.
Can I show you open my hand?
I love how one's white, one's pink.
Uh-huh. Now watch this. That one pinked up again.
Feels weird though.
Okay, and now I let go. That is called an Allen's test. You can go sit down. Thank you. That's called an Allen's test. What we were testing for, and Allen's is, just some guy's name. But what we were looking for is the circulation that's available in her hand, because if I do an ABG in the radial artery, she better have adequate circulation in the ulnar artery, because if something bad happens to that artery, it gets messed up in any way from doing an ABG, we're in trouble. She could lose her hand. So our responsibility is making sure we have adequate, sorry.
I'm just looking.
We have adequate function. right? We can look at capillary refill. We want to check both pulses. We want to do an Allen's test before the respiratory therapist comes to do an ABG. Now, last semester you covered ABGs. You'll cover them again this semester, just because we're really into respiratory now and pulmonary issues. Now, that's our responsibility before an ABG. After the ABG, our responsibility is what? Make sure they don't bleed, because that was an artery. So we hold pressure for 15 minutes. If the lab tech or the respiratory therapist doesn't do it, and then we check for hematoma and make sure that the patient is not experiencing any issues with circulation. So again, checking pulses, checking capillary refill. Now, do you have a lab guide? Does anybody have a lab guide? Yeah, if you would hand out the other lab guide to somebody. Ventilation perfusion scan. Would you look up ventilation perfusion scan? Would you look up CT scan? So while they're looking those up, I'm going to talk about MRI. We may do an MRI of the lungs to look for stiffness and look for structure. Before I send somebody to an MRI, what must I as the nurse do?
Allergies?
Okay, we can look for allergies. We don't really give them any drugs beforehand. So, we just always screen for allergies, so not bad. What else? We're putting them into a giant magnet. Good. Get rid of metals.
There's no ventilation perfusion scan, just venography.
BQ scan?
Oh, maybe.
Try BQ.
I sort of check if they like claustrophobic as well.
Yes. Okay, so before we send them for an MRI, remember that you're putting them into a giant tunnel that is a magnet. It's a giant magnet. I once walked into an MRI room and I was almost up to the machine when I realized what was going on. I was being pulled toward the machine by my stethoscope and by the scissors in my pocket. Okay? It was like scary. The two technicians had to come and drag me back and pull that stuff off of me. That's how powerful the magnet is. Somebody told me the other day that pew, the back of their earring took off and went under the magnet, and pew, the front of their earring did the same thing. And they said that somehow they have some company come in and they put a neutralizer, it's like a reverse magnet, towards the magnet, and they clean it once a month because a lot of people forget their metals. But when we're talking about metals, we're talking about if they've had a recent surgery, are we sure that all of the sutures or staples have been taken out? Most of those are surgical steel, so they're not necessarily going to react, but we don't want them to go beep, 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 but the patient D is. Replacement joints, knees, hips, shoulders, anything that we might replace, they're all done with titanium, which is not magnetic. So we still, however, like them to wait 6 months to a year after having placement so that we don't accidentally shift anything with the MRI. Pacemakers, the older pacemakers, a giant magnet turns them off, and so they can't have an MRI, ever. But the newer pacemakers, they're not made out of regular metal, they're made out of titanium. and the magnet doesn't work anymore. They control them with a cell phone. So we no longer turn them off by putting a magnet on top of them. So those patients can have MRI, but we still wait 6 months to a year before we allow them to have an MRI, so nothing goes out of their body and out of the system. And then simple things like removing watches and jewelry, removing earrings, necklaces, and then also we want to make sure that we remove the snaps from their gowns. Now, you're not going to sit there and pop the snaps off the gowns. Those are hospital property. We're not going to destroy them. But what we are going to do is switch them over to either a no-snap gown or a gown with plastic snaps. We even take them in an aluminum stretcher because aluminum is not magnetic. And then we also want to teach them not only what we're looking for, it changes positive and negative electrons so that we get an image, and the image is very high resolution.
And also too, if they're on tele monitoring, are you guys familiar with tele when they do have the electrodes? Some of those electrodes have metal in it, so they're not MRI compatible. So you have to take those little stickies off and put the
Plastic ones on.
plastic ones on.
We also want to ask them things like if they've ever worked with sheet metal or in an industrial kind of capacity, because some of those people will get shards of steel. We want to ask them if they've ever been a veteran or if they've ever been shot. Because shrapnel is also metal. And you can imagine what terrible things might happen if they were shot in the belly and they left some of the buckshot in there, but they saved their lives, and now we send them into the MRI and those little pieces of metal go right out the body. That would be bad, right? So that's why we screen our patients before sending them to MRI. Even though it's just a magnet, there are a lot of things you have to consider. After the MRI, what's our responsibility? Just teaching them what happened, what we saw. But there's no real responsibility to put everything back. I mean, if the EKG patches aren't working all that well, switch them back to the regular metal ones, but there's not a whole lot of actual stuff we have to do after. Now, what about the VQ scan? Have you found it?
Yeah, it's actually under lung ventilation scan, which is,
Lung ventilation scan.
yeah.
Okay, so this, they're actually putting radioactive markers into your body, and they're looking for the perfusion of your lungs. We can also do it in the brain or other body parts to see if there's a tumor or a blockage or a leakage. If blood goes where it's not supposed to, that tells us the tale. If blood stops and it should be flowing, that tells us the patient probably has an embolus. So what is my responsibility before?
You want to make sure that the patient's not pregnant or trying to, or like suspected of being pregnant or anything because pregnancy is contraindicated.
And that's mostly because of the radioisotopes.
Says presence of conditions that affect perfusion. So see if they have sickle cell disease or emphysema.
Now with a VQ scan, you have to be careful because they're actually going to get chemical markers. They breathe them in with xenon. And those chemical markers attach themselves to blood, and then you look with a magnet over top of them, or an X-ray over top of them. You're looking for the radioactive particles.
Does that make them feel any type of way?
Some people have told me that they feel kind of a hot sensation similar to CT dye. Now, during the scan, it's just important to monitor them for any allergic reaction to the radioisotopes. They are not radioactive, so patients' families don't have to worry about that. And then after the scan, just making sure that they are back in their room. But prior to the scan, we need to make sure they have a working IV, at least one working IV, and we want to get them prepped to go. And the prep is very simple, NPO, for at least 6 hours.
Okay. It says here there's no food, fluid, or medication restrictions unless by medical direction. And also that written and informed consent should be done.
What's that?
Consent.
Oh, yes, consent. Because it's invasive, we're putting radioisotopes in tonight. Okay. And I asked you to look up the CAT scan. So before I send a patient a CAT scan, what is important to tell them or do?
It says here, like, identify the patient 2 different ways, obtain a history, the same with the MRI.
Now, on this history, what are we looking for?
It says history of the patient's health concerns, symptoms, surgical procedures, any results of previously performed lab and diagnostic studies, which would include a list of known allergens, any allergies to latex, and anesthetics, sedatives, or contrast medium.
Now, how do we find out if they're allergic to contrast medium? What can we ask them? Shellfish. You learned about doing a CAT scan pretty much when you learned about doing a cardiac cath last semester. And it's essentially, if the patient is allergic to shellfish, iodized salt, shrimp, lobster, any of those things, they're allergic to the iodine in them, most likely. And so what we do with those patients is give them a different kind of dye. It's not quite as defining and it's not as good as the regular dye, but it'll work. We can also pre-medicate them with antihistamines and/or corticosteroids for a potential allergic reaction if they're allergic to the dye.
See, the main thing on here, like it has it on bold, is if the iodinated contrast medium is scheduled to be used for the patient who's receiving metformin, that you have to discontinue the medication or hold the medication for 48 hours.
Okay, so that's the other piece of history that we need to do. We need to find out, are they getting metformin? Which is also known as glucophage. Okay? So when you encounter me in the hospital, remember to ask me about my metformin. I take it twice a day. And so you don't want to do a CAT scan on me until that's out of my system for at least 24 hours. It messes with the radiology. Okay? Biggest priority is the allergy. Second priority is the metformin, because if we're going to do the exam, we want it to count. We don't want to have to repeat it later. And we want to look for BUN and creatinine and possible GFR. So if BUN and creatinine are elevated, what does that indicate? Surely somebody knows this one. BUN and creatinine.
It's like
Kidney function. BUN tells us the kidneys are functioning. Creatinine tells us they're but working hard. And then creatinine tells us that they're failing. And if those two are slightly elevated even, we might do a glomerular filtration rate as well. The whole idea is that the contrast dye can kill the kidney. It's a very giant molecule that gets stuck in there.
And they monitor it afterwards as well too.
Yes. Again, they also need to have an IV site for the contrast medium to go in. Either that or they drink the contrast medium Depends on what kind of test they're getting. After, we need to do what? Giant molecule, we want it out of those kidneys. What do we do?
Increase fluid.
Increase fluid by at least 1 liter. What's normal? How much do we normally take in? First semester stuff. Now, everybody knows the 8 ounce glasses a day.
Yeah.
That's approximately 2 to 3 liters. So we want to increase that to 3 to 4 liters, depending on their health, of course. Now, what if they have kidney failure and their GFR is high and their BUN and creatinine are high? Are we still going to do the exam? It's possible that we will. We just have to kind of collaborate with the physician to determine the risks and the benefits. If it benefits the patient more to find out if they have acute respiratory distress syndrome, then we might go ahead and take the chance. And then just flush them really well with fluid after the fact. And try to get that contrast dye out of there and keep it from clogging up the kidney. Okay, so my whole point is, when you are doing labs and diagnostic tests, you need to know what the nurse's responsibility is before and the nurse's responsibility is after. This little Davis interpretation guide has 3 sections in it under each exam. One is pre, one is intermediate, and one is post-test. It's not my personal favorite. I prefer Pagana and Pagana from Mosby. It has before, during, after, and it's just more friendly to my eyes. But anything we need to know is in this book. And we need to be responsible for being able to prepare our patient for tests, or whenever they come back from a test, being able to accept them safely onto the unit. Makes sense to everybody, I hope. Okay, so that's question number 3, how the nurse will recognize it. Ascending and descending, or in order of appearance, in order of importance or threat, list of the signs and symptoms, and then we want to know labs and diagnostic tests and what's my responsibility to send them there. What do I need to know about during, and definitely when I return or they return from the test, what should the nurse be looking for? And there is a possibility of a latent allergy even with the altered dye for people allergic to iodine. So we want to look for allergic reaction. What would an allergic reaction look like? Don't make me do all the work. What does an allergic reaction look like?
Just itching.
Hives, itching, purpura. Speak up, girls.
I don't know, I said like angioedema.
Possible angioedema. Anything from you?
Like I don't know. Pretty good.
How about a simple rash or a fever? Or anaphylaxis, meaning like their throat is closing up. That brings us to question number 3. And if you see something like that, ooh, threat of an allergic reaction, you better know what you're looking for because you're the nurse. Okay? And trust yourself, okay? That's the number 1 failure I see on tests, is that somebody second-guessed themselves or were afraid to be wrong. Don't second guess yourself. If you studied well, and the people who come to this have studied well, Your brain knows the answer. Trust it and move on. Don't talk yourself out of the good answers. Once you start analyzing, you've taken yourself completely out of that question and invented something new into the question that doesn't belong there. Okay? I see her blushing under her mask.
I just feel like you're talking to me right now.
It's just something like all of us. We all do that.
Everybody does it. I've seen like 4 different type errors. One of the major errors is that you just don't trust yourself and you start analyzing. And when you start comparing between one and the other, you start telling yourself, well, what about, could he have? What about if? Could she mean or could he mean? You start thinking like that and you start second guessing, well, if the blah, blah, well, was blah, blah in the stem of the question? No. So trust yourself. Your first instinct is almost always correct. Once you start analyzing, that's when you mess them up. Trust yourself. You've been here for 3 semesters. You're about to graduate. Learn how to trust you. Because you're that good. Woohoo! I'm that good. Come on, say it.
Woohoo! We're almost that good.
We're all that good. Speak it into existence.
That's right.
That's right.
Prophesy.
You know, a lot of times I'll send people home with homework to just go look at themselves in the mirror and give themselves positive self-talk. Like, I rock this. I'm gonna do this. I have got this.
You guys write it on your mirrors.
I need to.
Me too.
I just say I'm hot. Then I said, oh yeah, it's summer, it's 90 degrees outside.
All right? All right, so trust yourself. Read the question, read it 3 times, understand what is it really asking me. Then when you look at those answers, you eliminate 1 or 2, get it down to those 2, read the stem again with the first answer, read the stem again with the second one you've chosen. Whichever one sounds right, pick it and move. Don't compare, don't analyze, because that's when you walk outside of the photograph that you've been given to make this choice. So trust that your brain knew the answer because it recognized it, and then move on. Click and go. All right? You do that, I guarantee you will do well on your exam. I finally convinced somebody to do that, and they went from a 68 on the one exam to a 94 because they weren't missing all of those questions from second guessing. All right, so question number 4 is, we did 3, which is how is the nurse going to recognize it? We're up to 4. Question number 4 is, what does the nurse anticipate the physician will order? Okay, so number 1 thing for the physician to order would be oxygen. So we need to know a little bit about oxygen delivery systems. So there's a whole chapter on oxygenation. Go look at the different types and modes of delivery. There's also a video out there on oxygen delivery devices. For ventilators, intubation is very common with the ARDS patient. It's acute lung injury. And so, if they are intubated, our role while they're getting intubated is to make sure that they are sedated, make sure they are comfortable, and everybody hold your breath. That's about all I got in me. If that's all I got in me, that's all your patient got in him or her. So you better stop the person who's attempting. If you can't hold your breath anymore, you need to stop the people intubating and have them pull back on the tube that they've possibly not got in and hyperoxygenate the patient with bag valve mask. That's your responsibility to make sure their sats don't drop. And the way I figured out how to do that best was to hold my breath. And if I can't do it anymore, that means that the patient shouldn't have to. So you will be present for intubations, like on the unit sometimes, and that's what your role is, to make sure that, number one, they don't attempt too long. Because they will cause brain damage if they don't stop. Okay? Now, the next thing I need to know about intubation is that immediately following intubation, what do I gotta get?
Immediately following, once you want to verify the placement. Is that right?
So you wanna do what to verify placement?
Chest X-ray.
Yeah, chest x-ray. How else are we going to know where the tube is? There's a little radio-opaque stripe. It should be 2 centimeters above the bifurcation or carina. Immediately after intubation, we inflate the balloon. We listen for bilateral breath sounds because the most common thing is that it goes down the right mainstem and we only have one lung inflating. And then we also look for bilateral chest rise and fall. If it's doing this, that's wrong. It's gone down the right mainstem. We need to pull the tube back. We also want to measure that tube at the interior or exterior, doesn't matter, but always consistent. So you're going to document that when you document where it is at the lips. I use the exterior lip because it's easier to see. And there are little centimeter marks down every endotracheal tube. And usually 20 to 24 is the depth at which it sits. 22 being the most common. And then I want to make sure that things don't escape around that tube or get down past that tube. And so the tube itself has a little cuff on it. We want to make sure the little cuff that's down inside the tracheal tree or bronchial tree has enough pressure to hold things out, but not too much pressure to cause trauma to the esophagus or to the trachea itself. Now, I'm not going to tell you what the pressure is, but there's a little balloon on every endotracheal tube, and you can actually test the cuff pressure to see what that little cuff or balloon at the end of it, what kind of pressures it's exerting. What are they doing up there?
Moving stuff around. Furnace.
My guess would be they're probably waxing the floor, but at the same time, it sounds like people like wrestling up there. Okay. So after intubation, they would be placed on a ventilator. I'm going to try to make this as quickly as possible. Okay, so ventilator management. There are 4 modes to ventilation. The first one you are already familiar with, that's CPAP. It's continuous positive airway pressure. It delivers oxygen and pressures to the patient. It does not give a rate. The patient is responsible for their own breathing. It's like the CPAP machine you put on your patient at night. It's going to continuously blow air past them and help keep the airway open. That's it. The second one you need to know is controlled mandatory ventilation. Everybody raise your hand. Place it firmly over your mouth and nose. Okay, you can take a breath now. take a breath now. Okay, you get my drift. This is controlled mandatory ventilation.
So would that be assist control ventilation?
No.
Or the synchronized intermittent
No.
mandatory?
CMV. We only use it twice or in 2 separate occasions. The first time we use it, it may not be in the book anymore.
They have modes of ventilation and there's 4 of them, but they're not that. I was just wondering.
Controlled mandatory ventilation, however, is a mode of ventilation. You don't see it very often, but we see it in 2 occasions. The first occasion is complete sedation. So in the ARDS, ALS, ALI client, we may actually intubate them, sedate them, and control them because they have such air hunger because their alveoli aren't working that we can push in extra pressure or extra volume and we can control them and relax them with some sort of a sedative and sometimes even a paralytic agent. And we let the ventilator do all of the work and the patient's not going to bucket because they're completely out of it. The other time we use it is when the patient is literally under anesthesia in the OR. You're controlling them. They're not taking any breaths on their own. They don't need to. Okay? So CMV, what do you need to have whenever the patient is on a CMV? I'm putting a pillow over your face and I'm telling you exactly when I'm going to blow air into your lungs. And then I'm putting the pillow back over your face. What would you want?
Tell you when you're gonna do
What's that?
it. Tell me when you're gonna do it. I don't know.
I'd want to be sedated, folks.
So, because then I would know like when to take a breath.
I want to be sedated.
Is that the Ramones?
That's an actual song, by
Oh,
the
the
way.
Ramones, right?
Yes, it was by the Ramones. Somebody who knows her historic music. Okay. So yeah, you want patients on CMV to be controlled and sedated because that's a scary feeling. You can't suck through that ventilator to get your own breath. Now, assist control is the next one on the list. Assist control is the patient can breathe as often as they want to, but every X number of seconds, when it's supposed to, like clockwork, it's going to deliver its breath. Now, the problem with that is you get a lot of high pressure alarms because the patient will be at the end of an inhalation and the ventilator says, oh, time to give a breath, poop, and pushes one in. So everybody try that. Take a deep breath. Now take one on top of it.
That's too much.
Eventually it makes you cough because there's too much in that lung. All right, so that's called bucking the vent when you're coughing against the vent. So this one is used for transport because they're El Cheapo ventilators. We just have to make sure the patient knows what's going on and that we've put them on assist control. And what that means to their breathing if they're alert and oriented. We also use them as kind of a weaning device in post-anesthesia. They buck the vent, you wean them up down. They buck it again, you wean them down again. They buck it again, you wean them off. Poof, they're extubated and ready to go back to the floor. Okay? Okay. All right, so last but not least is SIMV or IMV. This is synchronized intermittent mandatory ventilations or intermittent mandatory ventilations. They're still going to get what the ventilator has been set to give, but it is going to like sense maybe 10 milliseconds before the next breath. And if the patient initiates that breath, it will deliver the bulk of the breath, even though it was 10 seconds early or 10 milliseconds early. Same thing if the patient doesn't take a breath, it'll wait for a few seconds and then go ahead and deliver the breath. So it synchronizes to the patient needs. If the patient is mid-inhalation, it'll just finish that breath to whatever you programmed it to give. It won't try to deliver its whole on top of what is already there, like assist control. All right, so it's like the kinder, gentler intubation. So that's SIMV. Now what are we delivering? Any of those modes except for CPAP is capable of delivering an FiO, well, even CPAP is capable of delivering an FiO2, fraction of inspired oxygen. Capital F, little I, O2, that's just the percentage of oxygen that the patient's getting. Fancy words, little bitty concept of saturation, of oxygen reaching their lung. Now, what else can we deliver? Well, we can deliver either pressure or volume. Now, pressure, it's going to push in air until it reaches a certain resistance, and then it's going to allow exhalation to occur. And the physician sets the resistance. Good for people with stiff lungs like the ARDSer, because we're overcoming pressures. The other thing we're delivering is volume. That's more likely. It's expressed as capital V, little t, or tidal volume. And it's actually liters per minute. If you look at it on a vent, sometimes it'll say 0.8. That's 80% oxygen. Or I'm sorry, 0.8 would be 800 milliliters. Now, that said, we go by height, weight, and body surface, but when we're calculating, we calculate on the patient's ideal body weight. I may be X number of pounds right now, but that does not mean my lungs got bigger. I just carry more adipose, not more lung. So that's why we're using my ideal body weight to calculate. Okay, next thing we're delivering, we can potentially deliver PEEP. It's not those little, chicky things from Easter. All right, so PEEP is positive end expiratory pressure. Now, similar to what we were doing before, this time take a very small breath, hold it. Now take a big breath on top of it. You can almost feel your air sacs recruiting open. Normally we have about 5 centimeters of water of natural pressure of air left in our lungs at the end of an exhalation. So that's what we call physiologic PEEP. Your pharynx holds it in. When we put a tube in, we negate that, so we will maybe sometimes give them 5 centimeters of water PEEP. That's how they measure the pressure, by the way, centimeters of water. In the ARDS acute lung injury patient, sometimes those PEEP levels will be up around 15, 20. I think 20 is the highest I've ever seen one go. But that leaves more air in the alveoli at the end of an exhalation, and then we're going to give them breaths from the ventilator on top of that. It recruits more alveoli. Remember the picture of the alveoli? It forces it to stay open and expand. Okay? Last but not, what's the danger of PEEP? Just think about what I just said to you, folks. I'm shoving extra air in your lungs. What's the danger of PEEP? If I keep blowing air into a balloon, what's gonna happen?
Damage to the lungs.
Boom! Yeah, pneumothorax, folks, pneumothorax. Yeah, it'll pop like a big old giant balloon. We don't want that to happen. So we try to stay with just physiologic or no PEEP. PEEP also squeezes the interior cavity of the chest wall because the lungs are bigger. It can squeeze the heart. So if that happens, the patient's blood pressure might fall. But primarily, blowing a bleb or blowing out the balloon is the #1 problem we have with PEEP. So anybody who is on PEEP, the best nursing intervention is to do what? It's not in the book. We want to look for bilateral breath sounds and look for bilateral chest excursions. Remember back in first semester, you put your hand on their back and look for your thumbs to go the same distance. That would be an indicator that they have a pneumothorax that needs to be dealt with. And then last but not least is pressure support ventilation. Everybody hold up your pinky finger. That is the size of your endotracheal tube. Now consider I'm breathing through a hole that big, kind of like a straw, and I'm sucking through all of this tubing that goes to the ventilator. That's a lot of dead space, isn't it? Pressure support doesn't deliver anything into the lung. It just eases the work of breathing by bringing it closer to the patient. So the higher you set it, the closer those gases are for the patient to sip to get their O2 or to get their breath. All right? Great for the COPDer because they've been for 3 days. Great for the ARDSer because they've got such air hunger. They're chugging like a freight train too, trying to get breath. Well, they exhaust themselves and experience respiratory failure because they can't do it anymore. So, put them on a little bit of CPAP or put them on a little bit of PEEP. Give them a rate of 10 and 50% FiO2. Calculate their correct volume and then give them pressure support to make it easy to breathe. What is the danger of pressure support?
Like what you said, hit the lung, like.
No, I'm not delivering anything into the lung. I'm easing the work of breathing.
Decrease respiratory rate.
Well, yes, it should decrease their rate.
Or
How about atrophy of the intercostal muscles?
because they're not working.
They're not working as hard. Had a lady, she was on a ventilator for 3 months. Every time we almost got her extubated, she'd end up back in the ER for another ileus colon resection. And she had come in for a fempop bypass, so she already had clots that we know of. Some of them broke off, and she kept going back to the OR, back to the OR, back to the OR. Well, we took care of her for almost 3 months that way. Well, by the time we were all said and done and her gut had finally healed and she had her colostomy and she was doing just fine, otherwise she couldn't breathe because she couldn't actually use the muscles. We had atrophied her. So we had her in there doing the isometric, I must increase my bust kind of thing. We had her in there lifting weights. Eventually she walked 50 feet down the hall pushing her own ventilator. And then she ended up going to Vencor. And they weaned her off within the course of 30 days. And she came back and brought us bananas. did. And the whole 3 months she was in there, her son would bring in bananas every Friday for everybody. Why bananas, I don't know,
So what
but
was the significance of the banana?
I don't know if there was any or not. But everybody was always pleased that Friday rolled around and we got fresh bananas. Okay, so those are the things that we need to know. You also need to know what causes alarms and what the nurse should do about them. So a high pressure alarm, what can cause it? Just think about a ventilator, where it goes, what it is, what would cause a high pressure alarm? What's that?
I said high pressure. Just ignore me.
What causes the high pressure though? You're thinking it. I'm gonna not stare at you, so tell my back.
If it's like there's too much air in the lungs, right? So the pressure. Can we discuss this?
She's
That
not the
makes
only one that
sense.
can answer. What was that?
I said that makes sense what she just said.
High pressure alarm. Yeah,
Pushed too
like
much,
we've pushed
yeah.
too much in,
Okay.
and so we reach a certain pressure, and it's a high pressure. Also, coughing causes a high pressure alarm. If the patient does this to their endotracheal tube, high pressure, they're compressing it, they have high pressure in the line. So anything that compresses the tube for any reason, including phlegm or secretions, or the patient just biting down on it, we have to do something about it. So if the patient's biting, we have two choices. We can sedate or we can just put in a bite block. If they're coughing, 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 get an x-ray. Make sure that it hasn't slipped down and it's touching the carina. Or listen to bilateral breath sounds. That's the first thing we do, is listen to bilateral breath sounds and make sure that we've got no secretions in there that need to come out. If we hear secretions, then we're going to suction them. But that's what causes high pressure alarm. What would cause a low pressure alarm?
Not enough pressure, or not enough,
Yeah.
Decreased breath.
yeah, not enough
Yeah, not
oxygen intake into their lungs.
Not enough physical air intake, but what could cause that, do you think? It's a closed system. An open in the system. So like where you suction, there's a little hole right there. If air is escaping through that little hole, they're not getting their full breath and the ventilator is going to alarm low pressure. So we look from the patient to the ventilator in that order to find out if there is some sort of a leak. And that's what causes low pressure alarms, and our responsibility to figure out what. If either of those occurs, the first thing you can do is bag the patient with the bag valve, no mask. Because if the machine is malfunctioning, then we would have to take over and fix it. Now that's not necessarily the first thing you would do. First, diagnose the problem and figure out where it's coming from and try to fix it that way. But if they still aren't getting enough air from or getting what they need from the ventilator, shut it off and bag them until you get respiratory therapy to get you a new machine. Pretty logical, isn't it? That brings us to the final question. The final question is, what can the nurse do? What are her priorities? And that's just basically a mini nursing care plan. In this case, we would look at acute respiratory failure, or we would look at impaired gas exchange. And it's related to an injury to the lungs, as evidenced by air hunger, decreased SAT, decreased ABG, increased respiratory rate. Now, going back to the patient's meds, we may give them corticosteroids in high doses. 3 things you need to know about all medications, and you want to look them up in your Davis Drug Guide. Why did I give it? So look at the action, how it works inside the body. Look at the therapeutic effect. Why did I give this drug? The nurse has been caring for a patient receiving prednisone or Solu-Medrol IV for pulmonary distress. Which of the following would indicate that the medication has been effective? Well, a decrease in the respiratory rate. Patient says his lungs feel more open. Now I need to also know what I should know, monitor, or do when giving this drug. If it's corticosteroid, what does it do? It increases blood glucose, it decreases the immune system. So I need to check for temperatures and BGMs. And possibly put them on insulin while they're getting it. I also want to monitor them for gastric ulcers. So blood in the stool, hemocolical stools. I also want to maybe give them, in addition to this med, giving them a proton pump inhibitor like Protonix or Prilosec PO, or via their PEG, or even IV, just to prevent ulceration from happening, because it will decrease the lining of the stomach. If I'm giving them bronchodilators, the whole idea is to open up the alveoli, but we definitely need to be aware that we need to monitor their heart rate and their blood pressure while they're taking albuterol. Because it does have some beta-2 effect, or beta-1 effect. Levalbuterol has 0 beta-1 effect, it's only half the molecule. But they use it as a last resort, not a first resort, because it's much more expensive. Ipratropium also works on lung tissues to expand. And it expands the alveoli. Some other interventions that we can do, and the physician will order, proning. Just like the COVID patients, ARDS patients get the rotobed, and they are rotated on a rotisserie. It's actually a rotobed, and it goes all the way to prone. If you don't have one of the specialty beds that does prone, they actually just wrap the person up in like a sausage. Somebody gets at the head of the bed and holds the endotracheal tube.
Respiratory therapist. The respiratory therapist knows does that.
Okay.
We always have to get a whole team.
And then we turn the patient onto their stomach. So somebody can reach underneath the patient and pull towards them, while the other group is pulling towards them, and we rotate the patient in kind of a sheet sack. One of my favorite critical care educators
What's it called, proning?
did a whole on proning, putting them in the prone position, laying on their face. But one of my favorite critical care educators actually put out a YouTube. You can look her up, Barbara McLean, M-C-C-L-E-A-N, like McLean. But it's a whole YouTube video on proning patients. She's a nurse practitioner out of Georgia. And she's been working the COVID unit. Specifically that COVID, But she started doing classes on how to prone patients. Because it's one of the things that works. Does anybody know why? Remember those alveoli that we talked about? And the vessels? Whenever you prone the patient, it pushes blood forward and it engorges those vessels so that even if the alveoli aren't expanding as much, you'll still get some exchange occurring. That's why proning works. Okay, I am going to hand it off to my esteemed colleague, who is going to cover your math, hopefully in 20 minutes flat, because I didn't leave her enough time. The second page that I handed you is actually your math. The blue page, please use those. Contact your instructor. They will send you a reading list. And go ahead and start taking notes. We just did the first ones.
Thank you.
Thank you, thank you.
Okay, how you guys doing with DA? The dosage calculation. Everybody feels comfortable with it?
Yeah, last semester I felt fine, but I haven't really looked at this yet, so.
Okay. So you want to read your questions carefully and make sure you decipher, see what the question's really asking you. So for the first one, what is the answer to the first one? And they want to hear, I didn't read it yet.
So, yeah.
What is the answer to the first one? I guess get to wipe this off.
If you guys remember.
You don't know?
As opposed
You guys
to
do know.
infusion, you run an infusion
No.
pump as opposed to what?
Huh?
No.
No. Anybody else has another answer?
I was like,
Wait,
an
I think I
infusion
just read
pump
it
as
wrong.
opposed to what else would it be run on?
Nothing else.
Okay, so
Wait.
So it would be yes?
So what is nitroglycerin?
It helps relieve chest pain.
Okay. And the question says, does it have to be run on an infusion pump?
So should this be,
Sublingual.
should this infusion, but it's
look at-
IV drip though.
I know.
Says not.
IV drip at 5 mCs per minute for relief chest pain. That is not
Oh,
Christ
okay,
sublingual
yeah.
nitroglycerin. So yeah, that would be the only way. I mean.
Correct.
Okay.
It has to be. It's a potent medication. It's a medication for chest pain. You want to make sure the rate is very much controlled. So just going forward, just about every medication is on an IV pump. Infusion pump, IV pump, same difference. That's what they're talking about. It's, you know, it's calibrated. Okay. Yeah. You'd rarely see things left open. You rarely see, like sometimes if you want to give a bolus, you want to give it quickly, the patient is very hypovolemic and they need volume, a lot of volume. You might see them open up an IV, take it off the pump and just open it totally wide. That's the only time you'll see just sort of hanging by gravity. Or if you have to give blood, if they're like very hypovolemic and they lose a lot of blood, again, you might see it open wide. But for the rule of thumb, just about every medication, everything you're given is going to be given an IV pump, just going forward. How is it delivered on the IV pump, do you know? How is a medication delivered on an IV pump? What's the settings? Mils per hour. So whenever you see anything that says it's going to be given by pump, it's always, always, always mils per hour. We will no means get through these, but if you want to scan through them and see if you have difficulty or what you think you might have difficulty with, we can do it together as a group. If not, you can just take it home and what do you have? What's the answer?
I'm not doing it right now. I'm not reading it.
I just did, is it 1.5 though?
I think that's correct.
Okay. So I put the done this in so long.
So where's your confidence? You gotta
Well, I mean, it's just been like so long.
pick, but the great thing is, nothing changes.
I know.
If you know what, if it, 1 and 1 would always be 2.
Yes. That is correct.
Look at that. This is number 5?
Yeah, number 5?
Or number 13. It's just the ones that like have a lot to it. You just look at them
Yeah.
and you're like, oh god.
We just get a quick
Okay,
so
you
used
guys,
to being.
how about try number 5?
Let's do it.
Yep. I'm done.
Okay, it's just saying what time. You already know what rate. It tells you what time it started. It just looks confusing because it's like D5 LR protection 10%. That's why.
Oh, yes, you do.
I don't even know
It
how to
runs
set
out
this
after 8.69 hours.
Okay,
Well, that's what I got.
Okay,
8.69
well, there you
hours.
go.
But then you have to add that to whatever 1940 was to figure out the exact time.
Well, there you go.
Oh, okay, well then I got that. But then
I got as far as 8.69.
Yeah.
So,
Okay, so
8.6, so what's 0.69 of an hour?
there you go. How would you figure that one out?
You would do
Oh, that's right. 69.
0.69
Yeah.
over 60, right?
So what are you looking for? What are you looking for? You're looking for minutes. You have to
Right.
convert that to minutes. So
Right.
minutes equals same thing. This cancels this out. So what's the?
Look at that.
You guys know it.
You made that so easy. 41.4.
Okay.
So
but you
8
can't
hours
get
and 40.
41 because you can't have
Yes.
0.4 per minute. So
Right.
8 hours and 41
Okay.
minutes. So it started at 22.
I haven't done a problem like that in a while.
No.
Oh wait, you started.
He's definitely just a while. He's definitely done that.
1, 2, 3.
I just took the hours. Oh, sorry. I took 1,000 divided by 115 and then 8.69
Divided by?
divided by.
It's gonna be 4. 4. It's like 421 or 420.
Exactly,
Yeah.
421. Exactly. So who's lost?
Can you just like work it out completely from the very beginning?
Okay, so,
That would be great.
alrighty, so we're looking, what was the initial thing we're looking for? We're looking for time, we're looking for hours, right? Okay, so hours equal, what do we know? We know that 1 hour, it was 115 mils, correct? I mean, yeah, mils per hour, right? And it's a 1 liter bag.
See, this is what I need. I need to see it out.
Oh, I thought you gave me 8.69, you told me
Yeah,
about
but it's just something
8.69.
about seeing it written out like.
Okay,
it's just-
how did you get 8.69 then?
By doing that, I just did
Okay,
it in like
okay.
on the thing.
Not a problem.
Okay.
Okay.
I just
So we're
need to
looking
see
for
it.
time, we're looking for hours. So we needed to know exactly how long it's gonna take to run that liter bag that's going at 150 mils per hour.
Right.
Yes, so that's how we got We got 8.69 hours. So we got the 8 hours, we had to convert the 0.69 to minutes. Always again, what are we looking for? Now we're looking for minutes. What do we know? We know that 60 minutes is 1 hour, and we have 0.69 hours. And that worked out to be 41 minutes. So it's going to take 8 hours, 41 minutes to run that liter bag. So we know it started at 1740, which is 20 to 8. Yes?
At 19.
I mean 1940. So, did I say 7? So I'm thinking because it's 740. Yeah. Sorry. Thank you for correcting me. So we know that it started at 20 to 8. So we needed 8 hours, which is going to take you to 4, right? 20 to 4. Yes? You got that part?
Yeah.
So now I have to add my 41 minutes.
Right.
So 20 to 4 is right here, so 22. So 5, 10, 15, 20, 25, 30, 35, 40, 41. So really this is 20 on the other side, right? So that's 5 after, 10 after, 15 after, 20 after, 21 minutes after 4. Just want to make sure, we're not going to move on unless it's clear enough to
No,
everybody.
yeah, it's just,
Okay.
I'm so used to the traditional writing it out this, that like if I don't see it, I won't, you guys can talk about it all day, I won't.
I'm with you. I'm with
I
you.
have to like physically see it up there.
Not a problem. So we calculate how long it took. It took 8 hours and 41 minutes. So I did 22, so we just work it out. Now I know another person actually added 24 hours and did the whole clock thing and did that, I'm like, I just did the clock and just like, okay, 22, 21, 20 to 8, 20 to 9, 20 to 10, 20, and did my 8 hours that way.
Micro drip, what was the, 60? It's 60.
Okay, smaller, right? And somebody said number 13?
I said 13 or 14. I don't know. Yeah, either one. I think they're the same, pretty much. Well, same setup. I remember last semester, I just can't remember how they set it up, but it was like a chart,
Oh,
like a table
let's see.
for these ones.
I'm gonna have to read it first, see what it says. So 13, the patient is receiving IV fluids, D5-LR with 20 MEQs of potassium, and 105, okay. Okay, so first of all, we want to see the total, how many mils of fluid will the patient receive at the end of an 8-hour shift, right? So we're looking for mils because we need total amount of fluids, right? Now, a few things to consider. When you're getting IV fluids, you have it going continuously, correct? So the pump is every hour this patient is getting 125 mils, correct? Within that 8-hour period, the patient is getting other medication as well. Now, diflucan is 100 mils there, okay? Then the patient's also getting levaquin, which is another 100 mils. The patient is getting Zantac over 24 hours, okay? It says that the healthcare provider does not want the IV fluid stopped for medication. So what does that tell you?
Everything's running.
Everything. So you'll see, for example, the term concurrently, simultaneously. Okay, that's also an indication that nothing is stopped. Versus piggyback. If it's piggyback, that means something is stopped, the maintenance is stopped, while the piggyback goes, correct? Or you might see single channel pump. That means they only have one channel, so only one thing can be run at a time. If they only have an IV site, if they indicate there's only one site, okay? But these pumps you can program the pumps where it can be going concurrently. So concurrently, simultaneously, together, doesn't want it stopped, it means it's going, okay? Everybody okay with that?
Yeah.
So we're gonna look at each one of them and we're gonna add up the total. Okay, because we know now, so it's going, so we're looking for meals. So the first part, meals equal, the patient has 125 meals per hour.
So times 8.
Okay, so meals equal, we have 125 meals per hour, right? Times 8 hours. How much is that?
1,000. There's the number.
Okay, 8 fives are 40.
Yeah, it's 1,000.
Okay. So if you want to, you're gonna have, so the D5LR. Oh, I was reading the other one there for 1 second. Okay. D5LR with potassium. In 8 hours, the patient had 1,000 mils. Yes? Okay. We're still doing 13, so we got that. Now the patient's receiving diflucan 100 milligrams in 100 mils of solution at 50 mils an hour. How much diflucan is the patient getting? 100 mils. So. Right? Because within that 8 hours, the patient had all the diflucan. Followed by Levaquin, 200 milligrams in 100 mils at 100 mils an hour. How much Levaquin did the patient get? 100. Okay? Did I lose anybody yet? Okay, everybody's good. All right. The patient is also receiving Zantac 300 milligrams in 250 ml over 24 hours. But we're only doing 8 hours. So over 24 hours, how much is the patient getting?
250 milliliters over 24 hours.
But we're not doing 24.
Yeah, so it's 83 for 8 hours.
Okay. Did everybody see that? Okay. I want to make sure we know how many mils. Patient has 250 mils. But we only want it over 8 hours. Oh no, that's over 24 hours, sorry. What did that come out to be? 80,
That's 83.
83.3 or something?
Yeah, like 23.
Okay. So in 8 hours, the patient had 83 mils of the Zantac. Yes? I want to make sure I didn't lose anybody. Okay. So we're going to add 83. Are we missing anything else? And then we're going to add them all up. 1, 2, 83.3. Because nothing was stopped. Supposed to try to do the problem. So we probably won't post it till at the end of the week or so.
Is it just the answers, or are you guys like posting like a work through of how to work it out?
It was just the answers.
Can you just do? Oh, no, never mind.
Which one?
No, it's fine. I think I've added some education. But if you're gonna post the answers, it's fine.
Which one are you thinking of?
It was just 17, just to verify. And that's probably what the easier one
Okay.
which is a factor.
Okay, so it's looking for the trip rate.
Yeah, so would you do 12, it's 12 drops per milliliter, so would you multiply that by 275 to get total drops for the
So you-
complete infusion, and then just divide it
So always
by
start
2.5?
with what you're looking for.
Right,
You're looking for drops.
right. Oh, wait. I have to do it, never mind, I didn't divide. 1 second.
What is the trip? Oh, 17, right?
Yeah,
Okay. When preparing an infusion of the 275 minutes of pepper, the mouth, okay. So we're looking for drops. So what do we know? What would I have here? Drops equal what?
12
Okay.
per milliliter.
Right?
Right.
So we need, how many mils do we have?
275.
Okay. And it's going to be drops per minute, right? $275
Right.
in 2.5 hours. How many drops per minute will you be getting?
I
Sorry.
put down 22, I don't know, but I did it differently, so I don't know.
So 22 drops per minute, you'll get to 275 over 2.5 hours, okay.
Is that what it is?
I don't know, I have to do it.
Yeah, 225.
22, yeah.
Okay. I just had done it a different way, so I don't make sure.
So always remember, what is the question asking? Just start with what you're looking for. And I think that's probably where students get into problems. It's like they'll read it and they're not sure what they're looking for. You're looking
Honestly,
for
just the drops. It said drops, and that's what threw me off instead of the GTT.
I forget that it's like.
But that's what
per minute.
GTTS is
per
drops.
minute per
It
hour.
is drops, right?
Yeah,
So drops is always per minute,
yes,
and then milliliters is over an hour.
correct.
That's just what I got confused.
Oh, okay. And when you see, whenever it says on a pump, it's always mils per hour. Pumps only goes by mils per hour. Okay? So if it doesn't have anything about drops, and it says what should the infusion rate be, it has to be mils per hour.
Right.
Because if you're looking for drops, it's gonna have to give you a drop factor. You would always see a drop factor in it because you need to know how many drops make a mil. Unless it just says micro drip, okay, or macro drip, right? It will give you the drip factor. I know it's been a while since you guys did this, right?
Yeah.
I do this, I use this a lot. I use my D8 a lot, like I worked the weekend, I had to calculate.
That's all we've ever done. We've never done anything with macro.
Well, no, it will tell you. So I did it, so
But micro is always 60.
micro is 60 drops per minute.
Right,
Mil,
always.
per
No.
mil. Per mil. There's macro too, I've seen, but yes.
Right, per
And it will
milliliter.
tell you the delivery drops is 15 drops per mil. It'll tell you otherwise. But if you just said by micro, then it's usually 60.
And if it's macro, it's always 10.
Macro is 10.
Macro.
Macro is 10, micro is 60.
And micro,
But
like
macro always
microscope
tell
is
you.
smaller.
Okay. Macro is 10.
Yeah, it would tell you the drop
Bigger
factor.
drops.
Yeah, it'll say the container that it delivers 15 drops per mil. So it'll tell you. So for example, this one here says this
But
is
micro
12
drip.
drops per mil. It told you there.
But micro drip, sometimes you don't say it.
If it's micro, it's 60.
Right.
So just a guide, start off with what you're looking for.
Now, if you would like some more tutorial on math and math things, go to your ATI and under your choices in products, and I think it may fall under a section called simulations, you actually have, it's called medication calculation 3.0. And it takes you through a lovely tutorial for orals, injectables of all types, IV, and and critical care.
See, even this is a secondary line, correct?
Right.
It tells you right here how many drops per mil. But nobody really,
So is that like minimum?
no, that's so this one here delivers 10 drops per mil.
That's cool, that's the macro.
This is macro, correct. But it doesn't say macro, it just says delivers 10
But I'm
drops
saying
per
like,
mil.
is that like the maximum amount of drops at all? Am I like, is there something wrong with my brain?
No, because you have micro, which is 60.
Right.
So is your questions asking me, does every
Oh,
secondary
it's like a
line-
bigger drop or something?
Yeah,
The drop
basically.
is actually bigger.
It takes 10 drops, make 1
One
mil,
mil, okay. What's
right,
wrong?
versus
Yeah.
60 drops.
Gotcha,
Making
okay.
the
I'm not
same
gonna
1
lie,
mil.
Yeah.
I'm not gonna lie, for a quick second, I just got confused too.
Right, no,
Yeah.
it makes sense, it makes sense. Macro, 10 drops per milliliter. so
Micro
things-
is very tiny.
Yeah,
Micro,
micro,
like
so tiny
microscopic.
drops.
So it takes 4 drops.
Right.
Got it. Got it. Fine.
There's nothing wrong with you, not today, maybe tomorrow, maybe. Alrighty, any questions, thoughts, concerns?
Did you guys ask about school? Are we starting the 24th?
Yes.
And are we only doing 1 day of clinical?
You're gonna follow, all the communication is gonna be through your professor's shell. So go through your course shell,
Okay.
and they'll keep you updated. Always, if there's any communication to be had, make sure you communicate using your Daytona State.
Are they waiting till
email.
August to start communicating with us?
Yeah.
Because nobody's communicating with us, or should we just reach out to them?
No, I'm sure they'll
You'll-
get
you'll-
it.
You'll get it, yeah, you'll get the information. We have another one.
Until August, you'll be looking at your Falcon Mail,
Yeah.
because you can't get into the course shell.
Yeah, there's nothing there, really.
Yeah, they don't give you access until, I think, midnight
The day before.
Mhm.
The day before. so.
Is Miss Petrarca not with us anymore?
No, she resigned, she
She
retired.
So what are they
She
doing
retired.
with those students? Because I have classmates that, like, they were just
I'm-
asking about that, like, are they
Oh, you
getting
are?
assigned to another
Oh, that's
teacher?
Oh, we have another professor.
Oh, that's
Oh,
taking
yeah.
over a class?
Yes, we have another
Like a
professor.
new one or just like someone?
I'm not sure if it's gonna be somebody that's just shifting around, because we have professors who shift around. They go to different semesters, different locations. So we're not sure, I'm not sure who it is yet.
If it's Meryl.
There's no spot left, so.
Okay. So just stay abreast of your emails. And when you communicate as well, make sure you communicate using your Daytona State.
Okay.
Okay. All the very best.
Thank you so much.
Okay. I hope this was helpful for you guys to get back into that school
Yes,
mode.
it honestly was.
I have one more question, but
Certainly.
it's just not about that. How about, would I go about changing my name? Because it still has my name and last
Maiden
name.
name.
But I want to graduate with my new last name.
Did you talk to anybody in the nursing office?
No, not
Okay,
yet. I
so
just did
email
just call them.
email Maria Smith or
Okay.
Patty Dabney,
Okay.
and they can tell you how to go from there.
Okay.
Okay.
You want to be a girl?
So congratulations.
Thank you. I waited, said it was mess up my financial aid, but
Yeah.
I'm not getting financial aid this semester, so.
Oh, I'll spray the stuff down.